Welcome back, everyone, to Living Beyond Breast Cancer's 2018 Conference on Metastatic Breast Cancer. I hope you've been having a good day so far. How's it going? Good? Thanks so much for joining us this afternoon. For those of you who don't know me, my name is Janine Guillemino, and I'm Senior Director of Programs and Partnerships at Living Beyond Breast Cancer. And we're so pleased to have you here and to welcome back our web stream audience. So if you could say hi to them, they're back with us right now. Thanks for joining us. So you're in our second keynote session, Ask the Experts, Managing Symptoms and Side Effects. And this is a really critical part of living well with metastatic breast cancer. So we're excited to do this today. And we're doing our plenary a little bit differently than we've done it in the past. It's 60 minutes of Q&A. So you guys set the agenda, you help us decide what we're going to talk about. And I'm really excited to have this very distinguished panel with us today to have a great conversation. So we'll be asking you to text all of your questions to 610-365-7532. I promise that's the number. And we're also asking you to text in your best tips. And when we can, we'll interject and share your tips with everyone else. So just a reminder, we will be recording this. You'll be able to watch it afterward. And we will be sending you an evaluation after the program. We do want to know how you feel about it. So I would just like to quickly introduce our three panelists. We'll start with Dr. Dizon, who is a medical oncologist specializing in the care of women's cancers and the sexual health of people who have been treated for cancer. So welcome, Dr. Dizon.
Thank you for having me.
We're also happy to welcome Dr. Pamela Ginsberg, a licensed psychologist who specializes in women's health and wellness. Thanks for joining us, Dr. Ginsberg. And last but certainly not least, Dr. Heather Wright, who is a naturopathic doctor specializing in the integrative treatment of cancer. Thanks so much for joining us. Nice to be here. So while we're polling for questions, I thought we could start, Dr. Dizon, with talking a little bit about fatigue, which is something that every single person with metastatic cancer faces at some point in their treatment. If you could talk a little bit about the causes of that.
Well, yeah, it is a ubiquitous problem. Most of my patients at some point will just get very tired of living with this disease. Some of it is because of the physical side effects of either the cancer itself or its treatments. If anybody has been on chemotherapy for years, this is not a surprise. But we're also learning that patients who have been on endocrine therapy for more than 5 years, going on 7, 10, 15 years, it does wear on their bodies as well. We also know that there's a huge psychological aspect to fatigue, that the mental challenge of being optimistic does weigh on people, and particularly for caregivers and family members, the conversations that you really want to avoid is a huge drain, not only on the folks that love you, but on yourself, because there are just certain topics that you just don't want to go to and where you're not ready to. And all of this in combination, I think, makes it really difficult. Now, the hard part as a medical doc, and I'm really, really grateful that there's other experts here, apart from just medicine, is that we don't have a magic bullet for fatigue. We can treat depression, we can treat anxiety, we can treat pain, we can treat your cancer, we can treat most side effects, but something that's overwhelming, something that's so permeative, like fatigue, there's no one magic bullet. If you look at the data that we were able to generate, the only thing that seems to help fatigue is steroids, which is not without its side effects and is certainly not a long-term solution. And all of the studies conclude that way. So this is where I do rely very much on our colleagues, much like the ones on the panel, to help address that as well. So.
Yeah. I think fatigue, it's something that all of my patients talk to me about. It is ubiquitous. And the issue that I see is that fatigue is so distressing. It so influences your quality of life. And you are managing a diagnosis where your quality of life is really everything. What we're trying to do is have you have good quality of life. And when you have fatigue that slows you down and limits you, and then you're distressed by the fatigue, it really decreases your overall sense of life satisfaction. And so some of the things that I talk to my patients about is regarding being with fatigue rather than fighting against fatigue. If you think about where your energy is going, if you're angry because you're fatigued, some of your energy is actually going towards anger. So the idea of allowing fatigue and working with it and around it rather than against it is something that I often will talk to many of my patients about. Again, it's something that it should be addressed with your oncology team. If it's there, we know it's there, and there are some things that we can do to ease the burden at times.
Are there any naturopathic methods that people can use to battle fatigue?
Yes, there are. And like my colleagues here, I agree that fatigue is multifactorial, but there are some mind, body, and natural therapies and lifestyle changes that people can make to really support fatigue. And one of the challenges in natural medicine is that the evidence base is really limited. So the human studies are fairly small, but there is actually one study I'm thinking of to share with you in breast cancer survivors, where the mushroom called reishi ganoderma in 1,000 milligrams per day was shown to decrease fatigue, significantly decrease fatigue. So things like that, and supplement quality is very important and something to always discuss with your doctors and clinical teams, but there are a number of things such as reishi ganoderma, exercise, relaxation therapies that can really benefit those who are fatigued. Yes, reishi ganoderma is a mushroom. Okay, ganoderma, Ganoderma.
Oh, okay.
With a spelling bee.
You do that with the oncologists who say the medication names too, so now we're also going to do that with you. Kathy, can we take a question from the audience?
Yes, this is a little opposite from naturopathic, but what about Adderall for fatigue?
So the only place I've actually prescribed Adderall was for women in college who were diagnosed with breast cancer and really refused to abandon their college courses. It was that important to them that they continue. So it's anecdotal. We don't have much data about Adderall, particularly in women living with metastatic disease.
Thanks for answering that question. And I want to kind of turn to another issue that's coming up in a lot of our questions, which is managing pain. And pain obviously has both an emotional element and a physical element. And just wondering if each of you could speak a little bit to ways that people can manage pain.
Well, pain is it's a very loaded topic right now because we're in the midst of an opioid epidemic. Certainly most states are putting severe restrictions on us prescribing opiates. What I can say is that oncologists have a pass, at least in terms of our ability to prescribe opiates. Having said that, we don't consider opiates the be-all, end-all of treatment for pain. So it puts us in a double-edged position. We certainly want to help you control your pain, if not get rid of it completely, but we also have to be cognizant of the fact that that might not be the best solution. So the World Health Organization has a pain control pyramid, and that pyramid begins with anti-inflammatory agents. So we try to maximize the anti-inflammatory aspects of control. Then we go to weak pain medications, weak opiates, before we go to the stronger ones as well. And we use the strong opiates sparingly. And then we also try to convert those into longer acting medications. But again, just like fatigue, there are supplemental ways to help control pain. And again, it very much relies on a multidisciplinary approach.
Yeah, and as a psychologist, I always have to walk very carefully here because what some people automatically assume when they talk to a psychologist about pain is that that I'm going to say that it's in your head. Pain, of course, is in your head to some degree, but your perception of pain is influenced by many, many factors. So if you think about the difference between pain and suffering, pain is the physical experience of pain. Suffering is the emotional experience of pain. And so what you can address when you're not addressing pain through other medical means and other naturopathic means, you can address how much you suffer with pain. So doing certain things like working on optimism, doing mindfulness practices, relaxation practices, that decreases your suffering and therefore decreases your perception of pain. So there are psychological factors. It's very well researched. It's a really well researched area.
Yeah, and as a naturopath, I would say one of the things I see women struggling with in terms of pain management is that they have a desire to not use pain medications. And so oftentimes I'm supporting people to actually use them to relieve their pain and to really communicate with their pain management teams, but also to help reduce the side effects from pain medications, which can be really troublesome for people. So keeping the digestive tract and the bowel moving are really where I support people who are on pain medications. The other thing I wanted to say about pain was that the National Cancer Institute has a new definition of distress and cancer-related distress that now includes physical pain. And I was really pleased to see that because, as my colleagues are discussing, pain is very, very individual. For some people, it can involve a physical component and a mental, emotional component. And it's really important we recognize the individual when we're treating pain.
Thank you for that. Kathy, can you take the next question, please?
Sure. Someone writes in that her doctor will not approve acupuncture for pain. And what would you suggest she do about that?
I guess I'll field this one. So I work with a community acupuncture clinic here in Philadelphia called CAMA, the Community Acupuncture Center of Mount Airy. And I work with a variety of licensed clinical acupuncturists who specialize in cancer. And I do know that in some states, you actually can have a number of prescriptions for acupuncture that may be covered on your medical plan. I always advocate for people to speak with their oncologist really honestly about their options and desires to coordinate natural and integrative therapies with their cancer treatment plan. And I think it also is worth taking the patient out of the middle, asking your acupuncturist to communicate with your clinical team and vice versa. I think that can clear up misconceptions and help all the clinicians become aware of their background and training and create trust in supporting their patient in the best way.
I think from my perspective, when it comes to integrative therapies, I adopt a fairly low bar. If it's not going to put you in financial distress, if I don't see any harms for it, and if you really want to try it, then I shouldn't be standing in your way. So for whoever that asked that question about acupuncture, the question you should be asking your doctor is, why wouldn't you? And if he can't answer that question of why you will not prescribe this, then there's something that he's reacting to that has nothing to do with you. So my advice in that situation is have the acupuncturist speak to that doctor, or else get a second opinion. In the worst case scenario, get another oncologist.
Thank you for that, Dr. Dizon. The next question, I think, is for you, Dr. Ginsberg. And this is a question from someone who's asking how to deal with a spouse who's having a harder time coping with a metastatic diagnosis than you are yourself, and any tips that you would have for having that kind of conversation?
Yeah. What we know is that cancer affects everybody in the family. It doesn't just affect the patient. There are reverberations of being treated for cancer, and metastatic breast cancer specifically, throughout your family and friend circle. And there are people who are going to cope well, and there are people who are not going to cope well. And there is help available for all of them. There are free services available. There are individual therapy services available. And if you have somebody who's very close to you in your inner circle, that closest circle, who is not coping well, I strongly encourage you to reach out for help, because so much of it is about fear. And I think for spouses, much of the time, there's a sense of helplessness that is really difficult, that's genuinely difficult. And that helplessness can lead to paralysis or withdrawal. And we don't want to see that happen, because we want people talking to each other, supporting each other. You want to have a team approach to everything that you go through as a cancer patient.
Dr. Dizon, did you have anything you wanted to add?
No, I would just back up everything that Dr. Ginsberg said. I think it's very hard to be strong. And that goes beyond just the person with cancer. My best friend, Christina, died of metastatic disease before she turned 45. But before she did, she would tell me how her husband would retreat to the bathroom and cry. And he never told her he was doing this, and she never told him he knew. But I knew he was doing it. And that just put it into such perspective for me that everyone around you really wants to be strong for the woman or the man with metastatic disease. But it's hard to, it's almost, and I can't say this, I'm going to be very careful when I say this, it is as hard to watch someone you love going through something you can do nothing about, that they would rather take places from you. That is just devastating. And until that person realizes that's the situation they find themselves in, maybe the role of the woman or the man who's facing this disease head on, because you have to, is to be the one to call for help.
And if I can just add something to that as well, there's a phenomenon called protective buffering that happens very often in families. And protective buffering happens when the patient kind of stops talking to his or her spouse or closest people because they don't want to further burden them with their own emotional baggage. And then the spouse or caregiver stops talking to the patient because they don't want to further burden her with their difficulty. And so what happens is everybody stops talking to each other about things that really matter. And we don't want to see that happen in families. It really makes people feel extremely isolated and alone as they go through this experience.
And what I tell, so when I take off my oncologist hat and I put on my sexual health provider hat,
There's a hat for that?
there is. It's nice. It's really pretty.
Where can I get one of those hats?
You know, it's bejangled. But if you just wonder, I mean, it's so difficult to basically, call one of your docs and say, my husband is having a hard time, but I don't want to tell him I'm calling you. So what I tell folks in that situation, whether it's sexual health or just this family issue, is, don't say you are having this bad time. Just say, I am worried about you. I am worried that this is killing you. I want you to get help. I'm going to do this for you. Rather than saying, would you let me, because you're having a hard time. It puts you on a defensive if you're on the other side of that you. But if you say, it's me, I'm the one who's looking at you, seeing you suffer, and I want to help you. That's really powerful, and it gives you power in a disease where you've lost so much power.
Thank you. Great advice for many types of communication around issues with this disease. Kathy?
We have several questions about hot flashes, and One is written out, hot flashes, exclamation point, exclamation point, exclamation point. So I'm wondering what the panel, you each probably have a different perspective on the answer, so.
I really believe in the naturopathic approach.
There are a number of approaches. So one of the strategies that has some level of evidence and very much safety to support its use is magnesium for hot flashes, which can decrease the vasodilatory response in relation to hormonal changes that may be caused by aromatase inhibitors or other treatments you may be on. Magnesium comes in many forms, so the first question people ask is, what kind of magnesium? And the magnesiums that you usually find over the counter are meant to help with constipation or draw water to the bowel when you take them, like magnesium oxide. And some forms of magnesium are slower to be absorbed than others. So one of the magnesium forms that's been studied that supports reduction in hot flashes is something called magnesium glycinate. So in doses of 400 milligrams daily or twice daily, that can be supportive for some. Another natural therapy that's been supportive to reduce hot flashes is vitamin E, mixed natural tocopherols. One of the problems with over-the-counter vitamin E is that DL-alpha tocopherol is completely synthetic and will have no benefit for you in terms of your health. So mixed natural tocopherols are the key words there. And 400 IUs or international units of vitamin E daily or twice daily can help reduce hot flashes for some people. But there are a variety of strategies, and really depending on the way that you experience them. Some people have hot flashes that are worse at night, some are worse in the morning. There are very individualized, tailored natural approaches that could be looked at as well, such as homeopathy. So I hope that answers from my perspective.
Yeah, this is another pain versus suffering issue. So we know hot flashes are very uncomfortable. But the suffering that happens with hot flashes is a psychological response. And so when people are getting many, many hot flashes or they're being kept up at night because of hot flashes, it is extremely distressing. And that distress can actually make the perception of those hot flashes, how you feel them, much, much worse. And so what we want to do is we want to settle people down in terms of the anxiety that comes with hot flashes and the anger that comes with hot flashes and the sadness that comes with hot flashes. So all of those things can be addressed. One of the other things that I have found works for many of my patients is tapping. Do you guys know about tapping? Tapping is also known as the emotional freedom technique. It's a technique that stimulates acupressure points. And you tap on various parts of your body during a hot flash, and it seems to reduce the intensity of the hot flash and the duration of the hot flash. Also doing certain breathing exercises. There's a breathing exercise called 4-7-8 breathing, where you inhale to a count of 4, hold your breath for a count of 7, exhale to a count of 8, especially during the night. Doing 4-7-8 breathing during the night when you're having hot flashes or night sweats seems to reduce the intensity.
And then we actually did some very nice work. We did a randomized trial of hypnotherapy, actually, for management of hot flashes after a breast or a gynecologic cancer. And actually, hypnotherapy is an effective strategy as well. Acupuncture is another non-pharmacologic approach to this. If you're looking for medication, your standard antidepressants can oftentimes help with hot flashes. So there's a lot of strategies. If you are not one who wants to add another medication, trust me that there are many ways to handle this as well.
One of our attendees said that her gynecologist has suggested taking baby aspirin to lower histamines and to try black cohosh, and I'm wondering whether you have thoughts about those.
Yeah, both of those have evidence to support their use and are safe. Again, with supplements, it's very important to let your oncologist and clinical team know that you're taking those supplements. So if you are using black cohosh, I'm trying to think of the name of the very common over-the-counter black cohosh. Does anyone know what it's called? I'll think of it. But yes, black cohosh can be a very useful strategy as well.
Oh, Okay, thank you. There's lots of questions on joint pain and AIs. Dr. Dizon?
Well, so one of the biggest breakthroughs we've seen, actually one of the biggest findings, I should say, about the joint pains that come with the aromatase inhibitors is that if you're more active, it actually can help reduce the joint pain. You would think that if you're having all this joint pain, you want to rest. But one of the trials that was presented in the last couple of years showed that if moderate walking can actually reduce the amount of joint pain one is having. So, it's almost counterintuitive, but the more active you are, the more likely you are to have those joint pains controlled. What I will say, because we talked about pain earlier, opiates are probably the worst things for joint pain because they may not work, and if they do work initially, they will tend not to work at the doses you had because you develop tolerance. So I try very hard not to prescribe opiates for joint pain. I rely on anti-inflammatories. I have a feeling it's got to have something to do with the complete deprivation of estrogen on bones and muscle. And I think we are still looking into how best to address that. There's some very interesting data with some testosterone depot shots. It's in clinical trials. I would not recommend doing it off any kind of clinical trial. But taking a little bit of a break from an AI if you're having those pains, a 7 to 14 day time off period, at the same time starting a low intensity aerobic regimen and then reintroducing your medication, it might be effective. It's not to say that AIs are going to be completely fine after you do this. Again, with my sexual health hat on, I think they were some of the worst drugs I've ever seen in my life for what they do to sex lives. But they are incredibly potent drugs for breast cancer. Any advice otherwise?
I was going to say that some of my patients have questions about whether to continue their aromatase inhibitor because their joint pain can become so severe. And I do encourage that conversation with your oncologist because sometimes those can be switched to another aromatase inhibitor. And also I work with people to maintain flexibility and movement and support those lifestyle changes to keep good circulation going. And really, water and good hydration is so important to joint health. I was recently at a conference where Dr. Morse from Duke University presented his data, a clinical trial with women, metastatic breast cancer patients on aromatase inhibitors who used an olive extract supplement, which contained an active ingredient called tryphenol. And there is data to support use of copious olive oil as a dietary food regularly, such as is recommended by the Mediterranean diet, can be very, very helpful, anti-inflammatory, and support reduction in joint and musculoskeletal pain related to aromatase inhibitors. Finally, there's some level of evidence to support melatonin, that can reduce myalgia associated with aromatase inhibitors. And then fish oil is something I talk with people about, which helps decrease inflammatory cytokines and is very anti-inflammatory.
Thanks. We have a number of questions about another kind of pain, about neuropathy, and what people can do. A number of folks are taking gabapentin and wondering if there's any other options for managing it, whether there's a chance it will resolve itself or get better.
So unfortunately, the biggest tip that your oncologist will have for you about neuropathy is to bring it to their attention as soon as it happens. Because the worst thing I've ever seen is a patient whose neuropathy just got worse with each subsequent dose of treatment and really wanted to push through that therapy, and her last cycle was coming in a wheelchair, unable to walk. That is the biggest fear of all of us who treat cancer, that we're going to paralyze you or just take away your function while we're trying to do something good. So early intervention, it might mean stopping or delaying therapy until the neuropathy subsides a bit. It might be reducing your dosing or increasing the intervals between your treatments. But these are things that need to happen so that the neuropathy doesn't become persistent. I tell my patients who are on taxanes that the neuropathy is not permanent. In reality, there's about 3 to 5% of patients who will walk away from taxanes with a permanent neuropathy. In my experience, anecdotally, they all happen to be teachers. I think it has something to do with just using your hands, kicking the kids and slapping them around a bit. But for some reason, I think it's the increased dexterity in someone's work seems to predispose them to persistent neuropathic symptoms. This is, I actually refer quite a bit of those patients who are having such trouble with it to psychological help for the sole reason that we only have gabapentin. There's no real treatment for a neuropathy that can reverse it if it's permanent.
And again, when you're talking about psychological treatment for pain, it is not to say that there's something psychologically wrong with you. I can't stress that enough. It's just that there are psychological interventions that are helpful in many different areas when we're talking about pain. One of them is in terms of acceptance of your disease and some of the complications that will come with it. And again, working with that, those complications rather than trying to work against those complications. And so that acceptance is a really important part of your overall psychological health and the way that you will experience this disease and move through the trajectory of it. There are things like cognitive behavioral therapy that are very, very helpful for people who have pain. And again, it may seem like, how is that possible? But trust me when I tell you, the way we think about things affects the way we feel. And when we can show you how to think about things in a way that's more helpful to you, you will feel better. And the way that you accept pain or work with your pain improves dramatically.
And I should say, what you're hearing from the three of us is not choose which one you want to go with.
Right.
All of this is happening simultaneously. So I will be trying Neurontin while I'm sending you for psychotherapeutic help, while you're seeing a naturopath, so that you can come to me with their advice and we can work it out in terms of your oncological specific plan. But it takes a village to treat someone so that the quality of their life is as good as it can possibly be. Sometimes your oncologist just doesn't have all the answers. He may not admit it, but sometimes we don't have all the answers.
We have many questions about sex being painful because of treatment for young women who are put into premature menopause. I guess I'm looking at the two of you, but hopefully you'll have some to add.
So I'm actually speaking about this tomorrow, and it's going to be a talk specific to men and women living with metastatic disease.
And it will be webcast.
Okay.
So you can
and it will be
tune in.
G-rated, just so you know. And I will not be wearing a hat. So, but I'd be very curious. I mean, do you guys do you want to, because I do have folks who see a naturopath, and I do send folks for counseling, particularly with couples.
Yes.
Yeah, go ahead.
So there are people who specialize in sex therapy, and that's not the same thing as sexual surrogates. You're not having sex in anybody's office. Sex therapy helps you work through the hurdles that you have. And we know that the hurdles are there. But if you see a psychotherapist who is a sex therapist also, they really can help you talk with your partner and work on being able to face the things. It's such an emotional topic. It's so emotionally laden that it needs to be addressed. It needs to be talked about. It needs to be thought through. And the way that women, by the way, work through their problems is by verbalizing them. Women need to talk about their problems. So one of the things I said earlier today is when problems just swirl around in your head for women, it's one of the worst things that you could do to yourself. If you are not discussing the problem either with a girlfriend or a medical professional or your partner, you're really doing yourself a disservice, because women really need to verbalize their problems in order to help work them through. In terms of sex therapy, part of it is about acceptance, but part of it is also about understanding sexuality and understanding what erogenous zones are, and that your breasts are not the only erogenous zone, and that your vagina is not the only erogenous zone, that there are different ways of addressing sexuality that can be very, very helpful for you. So communication from a psychological point of view is really, really key, and just talking it through.
Yeah, and I guess very specifically, one of the things I hear from so many women is, vaginal dryness and atrophy from medications can really cause a disruption in their, sexual behaviors and lifestyle, but also can predispose women to recurrent cystitis and other downstream effects. And really talking with clinicians, naturopathic medicine has great solutions for things like that can occur. Is important, so that you can really be heard for the way your individual symptoms occur, and so that we can best guide you in management and seeking support for those.
One of the things that bothers me the most, among clinicians treating patients with metastatic disease, is that too often they're surprised that you mention this topic at all. So I ran a clinic at Mass General, a sexual health clinic, and it was not uncommon for breast oncologists to come to me and say, oh, this patient has metastatic breast cancer, it's in her liver. Who can see her for a sexual health visit? And I was like, well, I kind of run that clinic. And they're like, oh, but you only see women who are cured.
Oh.
So there is a bias. If you don't know about it, you haven't asked. You should be lucky you're alive. But that's not acceptable. So my talk tomorrow is going to be about, I want to empower you to ask the question, because if it's something, it can be this unspoken issue, and the reason it's so difficult for partners, primarily heterosexual partners, to discuss it is because literally men are from Mars, women are from Venus. You don't understand, well, you understand him very well, but he doesn't understand you at all, especially when nothing's working. So ask, empower yourself, and don't take I don't know for an answer. And I'll talk about this again tomorrow.
One of the things I said earlier, and did the discussion earlier today on dating with metastatic breast cancer, being single and dating. And one of the things I said that I say often to patients is that for women, we really, the first place that we get turned on is in our head. So for women, that doesn't come from between our legs, it comes from between our ears. So what's going on in your head, and you feeling connected, you feeling emotionally intimate with your partner, is the first place that women begin to get turned on. So it's really important, again, that communication and being able to connect with your partner. And if I go back to something that we said earlier, when you and your partner are doing that protective buffering, where everybody's kind of going to their separate corners and dealing with it individually, that is going to lead to a decrease in that sense of emotional intimacy. And that's going to be a problem for you when you try to have sex, because being turned on is going to be more difficult for you.
Yeah, so finally, if whether or not you come to my talk tomorrow, but you should, just think about how you define intimacy. All right, just think about and if you came here with a partner, whether it's a same-sex partner or a heterosexual partner, ask each other at the end of the day, how did you answer that question? It is shocking how different women and men answer that question.
Yes.
More tomorrow.
Good preview.
Also, I don't know if I can just throw out a resource, but I think everyone will be excited to hear about it. We call them bonbons or candy, but there's a company called Earth's Botanical Harvest that makes coconut butter-based vaginal suppositories. Some have vitamin E, some have simisafuga or black cohosh. And they can really help with lubrication and moistening of the vaginal tissue, and are really supportive of, comfort for intercourse. So I thought I'd just throw that out there. Enjoy some bonbons. Earth's Botanical Harvest. They make 3 or 4 actually vaginal suppositories. One's calendula based, one's vitamin E based, and one is simisafuga based. Those are herbs. And then, there are other things you can talk with your oncologist about. I remember my oncologist coming into my office and being like, what are we going to do? This person has, dry vaginal tissue. She's really wanting to have intercourse with her husband and enjoy her sex life. And can we give a little bit of estrogen using E-string, which is something that can be done as well. And we were really researching whether that enters the circulation and could promote disease progression in terms of providing that. And what we found was no, it doesn't. It stays very local, and it can be very supportive for people as well.
Hear, hear.
So
Absolutely.
yeah, a couple of resources.
So another question, we're talking a lot about communication, being able to think through what you want to say, and a lot of folks are texting us with questions about chemo brain, and just a lot of frustrations around forgetting words, having difficulty with executive function. Can you talk a little bit about some tips that people can use to manage chemo brain associated with metastatic disease?
Yeah. I'm going to go back to my pain and suffering. Chemo brain happens. We know it happens. The severity of it really differs tremendously for people. But how much you suffer with it also differs tremendously for people. So cognitive behavioral therapy really helps people kind of sort through their reactions to how they're thinking about chemo brain. There are, you can do brain exercises, you can do, they say do crossword puzzles and those kinds of things. And, they can have some benefit, but I think that the benefit to that is really more about feeling like you're doing something about it and feeling some increased confidence in having a sense of control, which helps. But again, this is about, there are changes that happen that if you are working against those changes, you are using your energy, your precious energy, to move you in a direction that's the opposite of where you want to be. So psychotherapy, obviously I'm a little biased, but I really believe, especially in metastatic disease, if you have never spoken to your oncology social worker or a psychotherapist throughout the process, I really believe that you should at some point, even just to kind of check in and get some tips, because this disease, people will talk about the difficulty of this disease and the medical part of this disease and how much it is to bear, but the emotional consequences of this disease are what most people say is the hardest part. And so if you're not addressing those emotional consequences, then again, you're selling yourself short. So it doesn't mean you're crazy. It doesn't mean there's something wrong with you. Nobody's going to give you a diagnosis of some crazy thing, but we can help you. We can help you cope with this incredibly difficult experience.
And I think one of the things that it's important to know about the loss of executive functions with chemotherapy is that, we've learned that it's not just chemotherapy. There's been some really very provocative work from San Francisco showing that women on AIs actually experience some cognitive loss as well. I like to reassure my patients that chemo brain is not part of the road to Alzheimer's disease. Okay? So it's usually short-term memory problems. It's not finding your car. You didn't used to make a list for the grocery store, but now if you can't write everything down, you won't remember things. It is not, I don't remember who my children are. It's not, I don't remember where I grew up. It's not that, and it doesn't become that. Okay, so it's really about short-term memory, executive functioning, adding complicated numbers, but it doesn't tend to get worse.
And remember, too, the way that memory works is with attention. So when much of your attention is on all of these other difficult things that you're managing, then you're not going to file information as effectively as you would when you're not stressed out. So stress affects your cognitive function in a very big way. And so again, addressing the stress management piece of this is actually very helpful in how people feel when they're talking about chemo brain. It seems to it increases memory if you decrease stress.
Okay. Lots of questions about targeted therapies and diarrhea and what we can do about that.
I got nothing to say about diarrhea.
So this is actually coming up a lot. We have a clinical trial at Brown looking at pertuzumab, and this drug causes so much diarrhea that there's a big argument among our breast oncology group. Part of us want to adhere to the trial and the label of the drug, because if we're changing all sorts of things, we won't know if the drug worked the way we want to give it. Other people are like, well, if you can't give the drug because people are having diarrhea, what the hell is the point of doing the trial? It's not feasible. So the things that I think are helpful about the pertuzumab is, again, talking to your oncologist, not when it's, I can't get off the toilet because I'm constantly going, and if I try to do something, then I'm going to soil myself. It's getting them when it's there early. So it's really about trying to educate, my job, educating you, saying, at the first sign, you're having watery diarrhea. It's watery, it's not loose, it's watery diarrhea. If you're having watery stools, you need to check in with me. So then we need to intervene at that moment, because it's you don't want to get behind the 8 ball on this. And then we can do things like dose modifications, we can dose reduce, we can dose delay. At the most extreme, and I've never had to do it, we can discontinue the drug, okay? But there are strategies to help mitigate it. There's medications that are available. I do rely on our naturopaths to help. Other things that you can do. I have a feeling, I don't know the literature on this, so you might, these drugs probably do cause a degree of lactose intolerance. So when someone is having a lot of diarrhea, I tend to tell them to stay away from dairy, just to see if it helps. In my experience, maybe half of my patients will have less watery stools if they get rid of dairy from their diet. And it's just milk, not ice cream. Milk, But for some reason, it just happens that way. I don't know, do you have?
Yeah, so I usually spend a good deal of almost every visit talking about digestive and bowel health with patients who are receiving chemotherapy. And one of the things that's a great tool that you can use is being mindful of your fiber intake, because really increasing the amount of soluble and insoluble fiber, such as one of the ways is rice. So rice absorbs a lot of water through cooking. It has a soluble and insoluble fiber component. It can bulk stool and really help the bowel to have a normal function and reduce diarrhea. Probiotics can be very useful. Making sure that you are adequately hydrated is super important, and having fluid hydration, sometimes by IV, can be necessary for people who are having unremitting diarrhea. So staying in good communication with your clinical team is essential. There are some homeopathics that can be supportive of people with diarrhea. There's some level of evidence to support glutamine use can reduce diarrhea related to some chemotherapy compounds. Other sources of fiber that can be helpful in bulk the stool and reduce the impact of chemotherapy for diarrhea are organic ground flax seeds. Sprouted grains like quinoa can be cooked and added to the diet. I'm often recommending about 30 to 35 grams of soluble and insoluble fiber a day. And cooked foods, cooked fibers, fruits and vegetable fibers, and pectins in applesauce are really helpful for people. So people with diarrhea and have a really sensitive gastric or gut mucosa from chemotherapy, I'll usually have them eat cooked food instead of raw food, because the raw food can actually inflame that mucosa further and exacerbate the problem. So those are some of the tips that I talk with people about.
Sometimes I will actually have people back off from chicken and steak even, and you just described the brat diet without the B.
Exactly.
So the brat diet, bananas, rice, applesauce, toast, and just do that for a bit until the GI tract becomes a little bit more regular. Again, with some bulking, with some antidiarrheal medications and antispasmodics, you can usually get into control. The key is just ask for help as soon as it starts, because you leave it alone, it's just going to get worse.
So another issue with some of the newer agents is mouth sores, although that's also an issue with some of the older agents as well. And some folks are wondering what they can do to manage those.
One of the new things that we're looking at that has some good level of evidence right now is called zinc carnosine. So this is a supplement that can prevent oral mucositis and mouth sores related to chemotherapy. I'm curious to know if you guys have a cold laser or a cold laser light in your clinical practice.
We do not. Usually we're still relying on magic mouthwash.
Oh, okay, yeah.
Yeah,
Most of my patients come to me hating magic mouthwash. Some people find me that way because it numbs the inside of the mouth, which if you're someone who your mouth hurts to even breathe, then magic mouthwash is a godsend because it will give you some relief for a few hours. But I find that regular intake of zinc carnosine can really reduce the exacerbation and the problem over time and is safe. And then cold laser light. It's a small blue cold laser that we can shine on the oral mucosa of the mouth that can help reduce the intensity of pain from mouth ulcers and prevent new ones from forming. And I've seen really good data on that presented at the Society of Integrative Oncology last year. So yeah, there are a number of natural therapies that can support. Some people are recommended by their oncology nurses to swish and spit with baking soda or glutamine, so those things can be helpful.
Kathy?
Not everyone in our audience has access to lots of specialty doctors. So I'm wondering, or not me, but others are wondering, are there people who do telephone consults, or are there resources like that available?
For psychotherapy, there are many resources available for psychotherapy, and it's not easy to find a psychologist who specializes in psycho-oncology, but through the cancer support community, they have a resource line that's connected to an organization called the American Psychosocial Oncology Society, and they can help you find somebody who may be local to you who is qualified and trained in psycho-oncology. Some of the other resources that are available to you, social workers are often available through your cancer centers, and if you don't have a specific cancer center, you should talk to your medical oncologist about who they would recommend and who they typically refer to. And then organizations like the American Cancer Society and Livestrong offer free phone counseling to cancer patients. So you can contact some of those organizations. Livestrong does, the American Cancer Society doesn't, excuse me, but Livestrong does provide free phone counseling with an oncological social worker. So there are services available. There's many free services available, and so I really encourage you to ask your providers.
I was just going to say, my organization is the Oncology Association of Naturopathic Physicians. It's oncanp.org, and there is a link to your state, and then you can look up a naturopathic provider in your area. Sometimes we're in hospital settings, and sometimes we're not, but many of us offer teleconsultations as well.
Yeah, and for those of you who may not be near a comprehensive cancer center or a big center in a city, they're coming up more and more internet-based companies that will put you in touch with a specialist. Two that I have worked with in the past, Infinite MD is one, and then I think it's MD Health is another. So these are not free, and I actually don't even know what the price is to do that. But for patients who don't have the access to a sexual health provider, there is a wonderful resource that was developed by Leslie Shover, who's a psychologist formerly at the MD Anderson, and it's called Will to Love, LOVE.com. And she's offering her services in partnership with the American Cancer Society on a clinical trial. So again, this is a wonderful web-based tool. You can do it on your phone or your computer, willtolove.com. I would encourage you to participate in the study.
So we unfortunately only have a couple more minutes. So starting with Dr. Wright and going down the line, if you have any closing thoughts or one tip on the side effect that maybe we didn't have a chance to address, I'd like to give each of you a chance to speak.
I would just like to address that the wisdom on the stage is so impressive, and the way that these providers are speaking about working with their patients is exactly the type of care everyone should be looking for and seeking out. And if you're not having that and not having that faith in your provider and that communication, then you need to seek good care and really advocate for yourself. And the one other thing I was going to say is that having a high regard for yourself and not letting negative self-talk interfere with your day and your belief in yourself as a strong, good individual is so important. Dr. Ginsberg was saying, with chemo brain, we can become really frustrated with ourselves, and just giving yourself a pass and knowing that you're doing your best and that you're fighting a disease that's very difficult and that you're a survivor at this point in time is so important. And I just honor all of you here today and thank you for being here and listening to us.
And I would say the wisdom is really out there. The wisdom is in the room. It's among you who are living this every single day. And I strongly encourage you to reach out for support. And so I have my support group right there. Hi, girls. If you, there are online support. If you're not going to have, if a face-to-face support group is not available, there is tremendous data that supports how much better people manage when they are getting support, when they are getting social support. So seek out the social support. Don't be afraid of that. I might be preaching to the choir because you guys are actually here, but for those of you on the live stream and for those of you who have never reached out for that, I really encourage it because I believe that that's really where the strength is when women are talking to other women about this.
Well, so, I think the one thing that we're learning, and it's alarming, but it's also happening on a national level that we're trying to address, is this whole issue of financial toxicity. So I need you all to start becoming engaged in your care. So the data that I just recently came across is that patients who are not doing well financially at the time of diagnosis, that doesn't impact how they do. But if what we do makes you, it negatively impacts you financially, that can be associated with bad outcomes. So the costs of care, whatever the value is of care, these are conversations. You need to be a part of it. You need to become engaged, and I would encourage you all to do it.
Well, I would like to give a hand to our three panelists for all their expertise. And thanks to all of you for your great questions. I'm sorry, my usual session apology for not getting to all of your questions, but you all had excellent questions, and hopefully we'll be able to answer some of them tomorrow. So I hope that you have a wonderful evening, and we hope to see many of you back tomorrow morning at 8 a.m. for the Reach and Raise yoga class. And if you want to see if you won a raffle prize, you should go to the LBBC table, and there will be a list of winners there. Have a wonderful evening.
Oh, this is nice. We should do this again.
I love stuff like that. I just think it's fun.
You know?